Hello everybody, my name is Richard Xia, and today we'll talk about point-of-care ultrasound assessing left ventricular ejection fraction using E-point septal separation. So learning objectives. We'll talk about what is E-point septal separation, also known as EPSS, how to use EPSS to assess left ventricular ejection fraction, also known as LVEF. The EPSS is used to estimate LVEF, or left ventricular ejection fraction, and it is done in the parasternal long axis view. To do this, you place the end-mode tracer over the distal tip of the anterior leaflet of the mitral valve. And let me show you. So it's about, the mitral valve is around here. So when you do the end mode, you make sure you place the tracer down, straight down like that, at the tip of the mitral valve. So when I play it, so it's around that area. Here you see this image is in parasternal long axis view, and when you place the end mode tracer straight down like so, you get image like this. And this is what end mode looks like on the screen. And here we have time going this way, and this is the depth of the screen. Remember, diastole is separated into early diastole and late diastole. And in early diastole, it's mostly passive flow from the left atrium floating into the left ventricle. And then in late diastole, you have the atrium that's contracting and pushing more blood into the left ventricle. So that's showing here. So here we have the anterior leaflet of the mitral valve. And as the heart is going to diastole, early diastole, you have this leaflet going all the way up, almost hitting the septum. And then in late diastole, this also moves up, but at a lesser degree towards the septum. So as it's moving in time, going from left to right, you see a larger peak and then a smaller peak. So the larger peak is termed the E point, and the smaller peak is termed the A point. And this corresponds to, that is the early diastole, so the early peak, and this is in late diastole where atrium contracts, so the atrial kick, and that's a lesser peak compared to the first peak, and this is called A point, like I said before. Here we have the septal wall, and this distance from the septal wall to the E point is termed the E point septal separation, also known as the EPSS. So let's just quickly go through this. Here we're showing the mitral valve waveform on M mode with the two peaks like I explained before. The larger peak is called the E point, labeled as E, and that corresponds to the maximal mitral valve opening. And then the smaller peak is called the A point, which is equals to the atrial contraction. And in normal EF, the mitral valve leaflet by visualization is very close to the septum during diastole. I also want to mention that the E point peak is larger than the A point because initially that's where most of the left atrium blood flows into the left ventricle. In people with normal EF, the distance between the E point and the septal is small. So remember this distance. So therefore, EPSS is negatively correlated with LVEF. An EPSS of 7 millimeters is evidence of reduced ejection fraction. EPSS can be used with this formula to estimate the ejection fraction. Here are some limitations of EPSS, and they exist in patients with mitral valve stenosis or aortic regurgitation. In mitral valve stenosis, there's decreased opening of the mitral valve. So if there's decreased opening, the valve's not really hitting that septum that well. So that distance from the septum to the opening of the tip of the mitral valve leaflet, it's going to be long. As a result, the measurement of the EPSS will be falsely high even if the patient has a normal ejection fraction. In patients with aortic regurgitation, the flow across the aortic valve prevents the anterior leaflet of the mitral valve to open fully. So this creates a functional mitral stenosis, and that gives you a falsely high EPSS measurement as similar to the concept mentioned above. This is my reference. If you thought this video was helpful, please like and subscribe and watch out for my next video. Thank you for listening.